So we've set the stage for our discussion of vascular flow. And we're going to spend quite a bit of time on capillaries. What direction do arteries transport blood? Away from the heart. Veins to the heart. Capillaries are the only vessels that allow for what? Exchange. Exchange of what? Gas, fluids, nutrients, wastes. If you have to exchange it with the blood, it happens in capillaries. Now, we talk about capillaries a lot. And I looked this up earlier because what was that percent of our capillaries that are filled with blood at any one time? 25%. That seemed really, really low.
3,600 square meters of surface area.
Hey, I looked up how many miles of capillaries we have in the human body. Keep this in mind. The circumference of the earth is 25,000 miles. Around there, 25,000 miles. Guess how many miles of capillaries you had if you put them end to end to end?
25,000.
Higher.
25 million.
What? That's a big jump. You don't know how to play prices right.
You just said higher.
60,000 miles. More than twice around the earth, you have that distance of capillaries in your bodies. See why you can't fill them all at the same time? Yeah, you would just be, you would just be all dried up if it was all in there. So as we look at the capillaries, we're moving large amounts of fluid. But again, 25% at any one time. That's why we shift it around depending on how we need to use the material. And so the way we control this bulk flow is we can either allow the movement of fluid out, go ahead and highlight, circle, out of the blood. If material, fluid moves out, that is called filtration. Filtration. And we're going to talk about the forces that are working to cause these things to happen, and there's two principal ones. And when we look at filtration, the driving force that is happening to move material out and fluid out is hydrostatic pressure. That is the pressure exerted by a fluid within a container or a vessel. What's another word that we can use in the human body for hydrostatic pressure? You measure it almost every time you go to the doctor. Blood pressure. So hydrostatic pressure, aka blood pressure, is going to be the principal dominating force that's going to cause filtration or fluid to move out. And here we've already introduced that's going to happen at this end, the arterial end of the capillary. So fluid's going to move out. That's called filtration. We also have another force that is working to move fluid back into the circulation. And if you move fluid back into a capillary, because that's the only vessels that allow for what? Exchange. Y'all are going to know that, if nothing else, by the end of the semester. Moving back in is called reabsorption. And that happens because of what we learned about in A&P 1, which is your osmotic pressure. What causes water to move in a direction when we talk about osmotic pressure? Osmosis, that's the mechanism, but what is causing the movement? Sugars, solutes. Sugar is a specific solute. Solutes in general, ions. What we're going to be talking about in the blood is not so much the glucose, not so much the sodium. What is going to be our solute in the blood that's going to attract water? Proteins. It's the proteins functioning as solutes, and when we talk about proteins functioning as solutes, we either call it colloid osmotic pressure, or simply put, oncotic refers to the proteins attracting water.
This is going back to a chart from our blood unit, but doesn't the pressure of the proteins kind of remain constant as inflow and outflow?
If you downloaded the PowerPoint, you know that's next on the slide.
Oh, is it?
Yep, we're going to look at that diagram and really hopefully understand that. So the two competing forces are going to be hydrostatic pressure to push out, causing filtration, and the oncotic pressure trying to pull fluid back in. The dominant one is going to dictate which happens, filtration or absorption. So here we go, Garrett. Here is where we're going to start. And we're going to start here with our arteriole. We don't see a precapillary sphincter, but we're just going to say this is a true capillary in our illustration. And we're going to start at the arterial end. And we've got the competing forces of hydrostatic pressure and our colloid osmotic, aka oncotic pressure. The protein's trying to pull the fluid back in. And which one is going to win is the key. Yeah.
Is it a combination of pressure gradients and concentration gradients that are influencing the movement?
Yes. And the gradients per se, or the pressure inside the blood and the pressure outside of the blood, that's going to determine the net pressure. Did you hear that? The pressure inside the blood versus the pressure out in the interstitial space. Interstitial means between tissues. And in this case, it's the space outside of the blood vessel. And so when we look at our hydrostatic pressure inside the blood, well, that's around 35 millimeters of mercury. Now, what is our textbook blood pressure? 120 over 80. You will probably be shocked how few patients you're going to measure blood pressure are ever going to be 120 over 80 exactly. So in this case, this is just a textbook standard to help us understand this concept. So blood pressure here in the arterial end of our capillary, 35 millimeters of mercury. That's the force inside trying to push fluid out. Now, outside the blood vessel, there's fluid, there's a space with a force trying to push fluid back in. But it's very low, practically zero. I like zeros and fives, so we're going to stick with that. So if you have 35 people on a tug of rope and they're pulling in one direction and you have nobody on the other end, who's going to win? The 35 people. So 35 people are pushing out and you got nobody pushing in, who's going to win? The pushing out. And so what we're going to see is we get our net hydrostatic pressure. We take the pressure on the inside, subtract it from the pressure trying to push in, and in this case, we're going to get 35 millimeters of mercury pushing out. That is our net hydrostatic pressure. That's one force, and we can see that happening right here. So now let's look at the oncotic pressure. The high level of protein inside the plasma. And what is our principal carrier that's going to help us with this the most? What protein? Starts with the A. Albumin. Albumin, and it's there to be a solute. It can be a carrier for other molecules, but principally it's a solute. That's why if you have liver damage from either hepatitis, liver damage from cirrhosis because you were an alcoholic for most of your life, the liver produces the albumin, and when you have patients that have liver disease, their body collects fluid. They have this really enlarged abdomen that's filled with this extra fluid called ascites. That's lymph that doesn't get back into the system because you don't have albumin. And this will make sense when we go a little bit further down the road.
That was called beer belly?
That's
Yes.
what I was thinking.
And those people routinely have long-term alcoholism and extreme liver damage when you start to see that kind of situation.
Would that be present in patients with like alcoholic fatty liver disease and cirrhosis?
Eventually, yes. I don't know at what stage that will happen. If your body can't produce or intake enough protein to keep that up, you can also see that. Because what do third world children that are malnourished, what do they look like?
Extended out.
They've got that huge belly, and that's ascites, because they don't have the protein in the blood to help them. Hugh?
So the protein concentration is higher in oncotic inside the bloodstream
Yeah.
than it is in the interstitial space.
Yeah, interstitial, we got 5.
Okay. Okay.
So we've got our net hydrostatic pressure, and we do the same thing with oncotic. We take the pressure inside that's trying to pull the fluid back in, and we got the pressure outside trying to pull or keep fluid out. And who's going to win this contest is pulling fluid back in. All right? So these are the two forces. Forces trying to push out, forces trying to pull in. Now, at this end, what we're going to do is we're going to see who's the winner. And we're going to talk about net fluid calculation to determine, are we going to get filtration or are we going to get absorption? So here is our net hydrostatic pressure minus our net oncotic pressure, and that number is going to tell us the direction of fluid flow. So we've got 35, right? 35 minus 0 is 35. For our oncotic pressure, we have 26 minus 5. That gives us 21. So after we do this calculation, we get a positive 14 millimeters of mercury. The number itself is not as significant as the sign of the number. Because when we see a positive number, positive means filtration is going to win. And the bigger the number, the more filtration you get. Make sure you note that. Positive net calculation is filtration, pushing fluid out. And on the arterial end of the capillary, that's exactly what happens. Fluid is pushed out, principally because of the net hydrostatic pressure that we have. Do you have a question, Garrett?
Yeah, so I was saying, so like that overall, we need patients to have positive arterial and capillary pressure.
If you've got good blood pressure, you're going to get that.
Okay. Is there any case where it'd be negative?
Well, once we get to the other end, that's what we're going to see.
So
Okay.
patients with edema, it wouldn't be negative?
Edema could be caused by an infection, some pathology, virus, bacteria, so that could happen. And that's a whole other mechanism of the immune system making your blood vessels leaky so more fluid gets out. So there's a lot of things that can cause that. Yeah. All right. So positive in the arterial end of capillary, fluid went out. Once the fluid leaves the vessel, now we call it lymph. And principally, we're going to lose fluid. We're probably going to lose some ions, but we're not going to lose a lot of the protein. Now, I think we've talked about this illustration before. If you've ever, and especially people that live in the country, okay, how many people, where are my country folks? Okay, in the summertime, if you didn't have a swimming pool, we didn't have a swimming pool, how did you play in the water? Pond or water hose? Yeah, water hose. You drank out of the water hose if you're going to admit it, right? Have you ever had that water hose that just laid out in the yard and you left the hose on? You leave it out there long enough, what's going to happen to that hose? It's going to bust. And once you get a hole in that water hose, if you try to squirt from the handle, what's going to happen? You don't have any pressure because the water's leaking out, right? Well, our fluid is leaking out just like that leaky water hose. So by the time we get to the venous end, what's going to be happening to that hydrostatic pressure? It's going to be lower. It's going to be lower. So now when we look at the venous end and we do that same calculation to determine, are we going to have filtration? Are we going to have absorption? Now let's look at what happens to the numbers. And I want you to see, basically, the numbers are the same except for our hydrostatic pressure inside the vessel. We've gone from 35 to 16. Why did it go down? Because we got a leak. We got a leak.
Did you say the venous end or our arterial end is known as the lymph side?
So lymph is the fluid when it leaves the blood vessel.
Okay, fluid out. Okay.
Yeah, the fluid that's outside the vessel is called lymph.
Wait, question. So those capillary sphincters that are controlling the,
How much fluid gets in?
and this is going out.
The arterial end fluid is coming out, so it's past the sphincters.
Oh.
Yeah. The sphincters can lower the pressure, but I think the sphincters are basically going to say, we're shut for business or we're open for business. It's not going to minutely regulate. So, all right, so we're going to do our calculation, but on the venous end now, and remember, only one thing is changed. That's our hydrostatic pressure inside. So when we look at our net hydrostatic pressure minus our oncotic pressure, which is still 21, but now because we started at 16, there's still very little pressure outside. Now 16 minus 21 is negative 5 millimeters of mercury. Now before we had positive 14, and what did positive mean in our calculation? Filtration goes out. Guess what negative means? Absorption, fluid coming back in. Because which force dominates? Which force is bigger? Hydrostatic pushing out or oncotic pulling in? Oncotic pulling in. Negative means pulling in. So what we basically have set up is we have set up, and this kind of reminds me of the hydrologic cycle in middle school. You know, the water evaporates, it condenses in a cloud, it precipitates and rains and back and forth. We've got this cycle of fluid out at the arterial end, fluid back in, fluid out, fluid in, fluid out, fluid in. Not 100% of the fluid that comes out, though, gets back in. A lot of that fluid that's in the interstitium, and that's in chapter 21, goes into the lymphatic vessels. And guess what the ends of the lymphatic vessels are called, because we need to exchange fluid, lymphatic capillaries that are going to take up the fluid and return it back to the heart. If you don't effectively return the fluid out of the interstitium, you're going to get inflammation. And there are diseases that parasites can infect the lymphatic system and block lymphatic structures or lymphatic vessels. So your lymph can't flow. Do you know what that disease is called? That's a cancer of lymphatics. If you block a lymphatic circulation and fluid continues to build up and build up and build up in the tissues, elephantiasis. We've seen the exchange of fluid. And that fluid out, fluid in is caused by your blood pressure. And where does the pressure of your blood really originate? In the heart, the contraction, the systolic and diastolic. So when we look at blood pressure, there's our 120/80. We're going to get that because when the heart undergoes systole and it contracts, that's the highest number. Diastole, what's the heart doing in diastole? Relaxing. That's going to be the lowest number. Now, as we move from our largest vessels, our elastic arteries, like the aorta, as we move to the muscular arteries, the big ones like the named ones, the subclavian, the celiac, now we are going to arterioles. What's happening, and what's one of the major changes and characteristics of the elastic arteries, muscular arteries, and arterioles? If you had to describe to somebody the difference,
Smaller diameter.
the diameter is decreasing. What's going to happen to the blood pressure as you decrease the diameter of the vessel? It's going to start to go down because it can't flow through as quickly. So look at what's happening to our pressure as we get into some of these smaller and smaller and smaller diameter vessels. Not only that, we're increasing the number of our smaller and smaller diameter vessels. So by the time we get to the capillaries, man, look, we're between 20 and 40. What was our hydrostatic pressure in the arterial end of our capillary? 35, right in this range. There's the arterial end, 35-ish. Coming out, we had 16. And so by the time we get into the venous system, our pressure is really, really low. And so that is one thing that happens as the blood flows through our body. We're going to have differences in pressure among our vessels. This is one reason why when you look at superficial vessels in your body, when you look in your wrist or in your arm, what color are those vessels? Greenish, blue. Those are veins. Okay, that design is intentional. Your arteries are deep within the tissue. Why? Where are you more likely to damage something, near the surface or deep? You don't want to cut a major artery in your arm. You'd bleed out. So that's why you have veins on the surface. One of the survival benefits of that.
Why?
That was in the last video.
It just happened that way.
It was.
All right. So your blood pressure again, hydrostatic pressure, we already talked about with the other slides. When we look at your arterial blood pressure, this is going to be what you hear when you're taking a patient's blood pressure. You're measuring the pressure inside the artery. Because the pressure's so low in the veins, you're not going to detect anything, and you're particularly not going to detect the pulse. The pulse of the blood, and it's that pulsation that we utilize to take a blood pressure. So again, highest pressure systolic, when the heart contracts. Lowest pressure diastolic, when the heart relaxes. You see the benefit of understanding systole and diastole in the heart when it relates to pressure. A&P1, A&P2, everything kind of meshes together. So we reinforce and we emphasize this as we look at new topics. Now, your arterial blood pressure is usually expressed as a ratio, 120/80. But you can also have the pulse pressure, which is the difference between the two. So what's your blood pressure? Oh, 120/80. What's the pulse pressure? 40. Now these are going to have various diagnostic significances when you're looking at a patient. Certainly you don't want these numbers to vacillate too much. Certainly you don't want them to get too high. I was the interim chair of biology for 3 years during COVID and all kind of other stuff. And by the time I finished, I went to donate blood, and they almost called the ambulance because my pressure was 190/110. That's stress. What hormone was coursing through my body 24/7? Cortisol, the stress hormone.
I guarantee if you took our blood pressure, they'd all be that when we walk in here for an exam.
On exam day? Okay. We need some anti-cortisol. We need some anti-cortisol. Yeah, bring your cuff for the next exam. So we also look at this one, mean arterial pressure. This is interesting because it's the average pressure of the blood in your arteries. And if you look at mean arterial pressure, it's not right in the middle. I mean, right in the middle would be 100. So your pressure, you see it's going to go up and down, but you see how as it's coming down, it's not just an up and down straight line. There's variations in that blood pressure through that cycle. So your mean arterial pressure, calculated in such a way, I doubt you ever have to do this in a clinic, but it's your diastolic pressure plus a third of the pulse pressure. And this is going to be somewhat of a telltale about how well are your tissues getting oxygen. Again, it's not the only number that's going to be significant. It's going to be a whole panel of things that you're looking at to try to understand what's going on with the patient. Because patients can tell you how they feel, but they can't describe to you a lot of the physiology that's going on to cause them to feel that way. So you're going to be running a lot of tests, getting a lot of numbers, and trying to figure out, okay, what's going on. So we've done the pulse. You see the up and down, systolic, diastolic. When you get to the arteries, there's no up and down. It's just smooth flow. And this smooth flow is going to continue as the pressure decreases and as we move into the venous blood pressure, which is, can you really call it a blood pressure if you're going to be about 20 millimeters of mercury in the venules, and by the time you get to the vena cava, you're practically out of gas. You're practically at zero, but that's fine, because what are we about to do? We get back to the pump and you recharge it. You re-energize it with more pressure and push it out again. Yeah.
Can you please explain real quick again how the mean arterial pressure determines how well the tissues are perfused?
So, and again, the clinical significance of that, I'm not sure, but when you look at the pulsatile nature, it's not just up and down. Right. It's up, shoulder, down. So it's not exactly in between diastolic and systolic. And it may be the extent of that shoulder that decreases that number a little bit, may be how long that force is pushing the blood into a certain tissue or out of certain tissue. That's my guess. Okay. I don't have the exact answer, but okay. So if we're at zero by the time we get back, how do we make it? How do we make it back? If you're in an airport and you've got to get to the next level and your legs are tired because you've already walked 10 miles through the big airport, how are you going to get to the next level?
You got a little track.
Well, you got the track that's going straight, but what if you have to go up?
Elevator.
Don't have an elevator, it's broken. What are you going to use? Escalator. You have additional ways to move. Well, the good thing about our venous blood, we have some accessory mechanisms for getting blood back to the heart. And I think I might have put this blood pressure thing in the wrong place, but we'll discuss the other pumps. I know it's in here in just a minute.
Wait, is that used all the time or just in cases where you just like don't have enough?
Oh, these accessory pumps are used all the time.
Okay.
Yeah. All right. I've included this because this is one of my favorite scientific words to say. It's just fun to say. The blood pressure cuff that you are going to use to measure blood pressure, whether it's using a stethoscope and looking at an analog dial, or whether you've got a digital reader, that cuff that squeezes you, and that is called an auscultatory method. Auscultatory meaning you're stopping the blood from flowing, and then you're slowly letting it flow again. This device is called a sphygmomanometer. Sphygmomanometer. Now, how many of you have seen the Muppets at any point in your life? Okay. Have you seen the guy on the Muppets that goes, mana, mana? Every time I say sphygmomanometer, I mean my brain automatically goes there. A sphygmomanometer, that's your blood pressure cuff. And when we look at what's happening when you put that pressure on the cuff, you are putting a significant amount of pressure that you go higher than the systolic pressure. So when you pump up that cuff in a patient that's 120/80, you pump up that cuff to 150, you've got the stethoscope on and you're listening, what are you going to hear? Nothing. Blood's not flowing. If you've got it at 190 like I was that day and you hear blood flowing, call 911.
I was going to say, crazy enough, national guidelines changed about a couple of years ago because so many people have high blood pressure.
Hypertension, yeah.
People, like, we're basically required, you pump it up to about 200, 220, feels really tight, and then you start there.
Yeah. I mean, if you pump it up to 150 and you still hear and then you're pumping more, there were, that one day when I was 190, they were pumping up, I was like, ow, 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 because it's like really tight. So you don't hear anything. Then as you start slowly letting the pressure off, the first sound you hear, systolic pressure, because that's the blood flowing through and exceeding the pressure that's trying to keep it closed. Now, when you get trained in nursing school, I have never been trained to take a blood pressure. I don't know. But I do know that when you get to the end and you hear a sound and then you hear silence, that last sound is your diastolic.
Yes, that's true.
They will talk about thumping sounds, muted sounds, tapping sounds, blowing sounds. But basically what's happening is when you get to this low point, there's nothing obstructing the blood flow, and blood flows smoothly in sheets. It's called laminar flow, and you don't hear any sound of the blood flowing. What you've done here is you've created turbulence, and you're hearing the turbulence you created by changing the diameter of that vessel.
It's actually pretty cool to hear once you've like
Once you've heard it?
yeah,
Yeah.
it is very hard to hear.
So
but
this is an example. You see the pressure exceeded our systolic. As you lower that pressure, you reach the systolic and you start hearing something. Then you come down until you don't hear anything, and that's your 120 systolic, 80 diastolic. And these sounds are called Korotkov sounds. That was, I think, Nikolai Korotkov from Russia in 1905. We're still doing things that we've been doing basically the same way since 1905. There's Nikolai. To me, that's crazy. Because are we using the same communication devices that we used since 1905?
nope.
I mean, how many have an iPhone 1? No, that's ancient, right?
Yes, very, very ancient.
All right. So now we get to the accessory pumps because of the low blood pressure we have in the veins. Now remember, our veins, what did we say? The venules were 20 millimeters of mercury. The vena cava were 0. So by the time we get into these large veins in our legs, we're probably single digits. And that's not a problem if you're going downhill, right? But what do the blood in your veins in your legs have to compete against?
Gravity.
Gravity. You're trying to launch a rocket and you don't have a lot of fuel. So remember, we have valves, unidirectional valves in our veins. So here, this is called a muscular pump, and we have it in our legs. As you walk, you see how your muscles contract and they squeeze the vessel? Well, your blood can't go down that far because the valves close, like your semilunar valves in the heart. It won't let it go backwards. But the blood in the top squirts up past the next set of valves. Now, when you relax those muscles, the blood tries to fall, but it's stopped. So you keep climbing the steps of the valves every time you walk and take a step. So that helps move the blood up out of the legs.
So is that why like more people who are more sedentary are more at risk for like from like embolisms? Or is there like a baseline rate of that your skeletal muscles will contract at?
Well, if you get a pulmonary embolism, which is a clot that makes its way to the lungs, what's one of the things that in relatively healthy people can cause that? Sitting for a long time, and particularly on an airplane with pressure changes. That's where you hear that happening a lot, on these long, long flights where your legs are bent. So you're not using that accessory pump, and your blood's kind of being constricted when your knees are bent way up in some of those tiny, tiny seats.
So like
There's those things are that squeeze your legs when you're in surgery.
Yes, absolutely. And people that have varicose veins are veins where these valves are compromised. They wear the support hose, like compression leggings, to try to help put pressure outside the vessel to help the valves work better, to make sure the blood is moving. Yes, we are meant to move. So we get the blood out of the legs. Well, we also have respiratory pump in our thorax, because when we breathe, when we inspire, we breathe in, we are causing the diaphragm to contract. And when we get to respiratory system, this is a little preview. When your diaphragm contracts, your diaphragm moves down because of the way it's shaped and its attachment. It's a dome at rest, and it's a flat plate that moves down when you inhale. I don't like saying inspire, because what's the opposite of inspiration? Expiration is not good in a clinical setting. Oh, the patient expired. They dead? No, he just breathed out. No. Exhale, inhale. And so when you inhale, the diaphragm contracts. That's going to increase the pressure inside your thorax. And that pressure inside the thorax, that's going to push on the blood in your veins. It's going to kind of have a rebound effect. It's going to push that blood up against that valve in the vein in your limbs, in your arms, so that when you exhale, now that intrathoracic pressure goes down, and now the blood is going to rebound and follow that low pressure into the vein that comes into the thorax. So it kind of creates a rebound effect, a low pressure gradient, so that's going to help pull the blood back into the thorax to help that low pressure blood get back into the heart. That venous return. We got to have the venous return. If our venous return goes down, what happens to your cardiac output? It's going to go down, right? So speaking of cardiac output, the more blood you get into the ventricles, what's going to happen to your blood pressure? More blood is going to mean more pressure, right? The greater volume of fluid in a space is going to equal higher pressure. So in this case, if we want to increase cardiac output, then we are going to have a higher blood pressure along with that. Now, peripheral resistance. When we talked about the heart, we talked about those factors that affect cardiac output. We talked about cardiac rate. We talked about stroke volume. Do you remember the third one? What force? The afterload force. That was the resistance of the blood vessels that we're trying to push the blood into. We can also call that afterload peripheral resistance. How much friction are we trying to push the blood into? Well, if our blood is too thick, that is going to increase resistance, and our heart's going to have to work harder, so our blood pressure is going to go up. What condition have we talked about that can cause your blood to increase viscosity, aka get thicker?
Get thick.
You remember polycythemia? What is polycythemia? Too many red blood cells. It makes it thick, syrupy. That's going to increase the viscosity. That's going to increase resistance, this peripheral resistance, and so our blood pressure is going to go up.
Viscosity.
So would dehydration do that as well, since there's less water in the blood, or no?
I think you're going to have to be severely dehydrated, but you could get to a point that it's so low, yeah. But I think if you get to that point, you're going to have a lot worse problems than just your blood being too thick. What else can increase peripheral resistance? Well, as the vessels increase in length, you've got further to move the blood, that's going to increase your blood pressure.
How does water get into the blood?
How does water get into the blood?
Because he's over here, he talked about dehydration. So if your water intake isn't as it should be.
Right. So you are going to bring water in from your intestines
Into the blood.
and your colon. Yeah, because the water is going to be brought in from what you drink and your diet through the dehydration that's happening for what you ingested in the colon. That's going to be brought into the body. Your kidneys are going to regulate how much water you have in your body by either producing more or less urine. But the way you bring in more is through your GI tract.
Okay.
Yeah.
So your mesenteric vein, right?
It will eventually get to that, yeah. But I mean, you're bringing it in through the mucosa of your gastrointestinal tract.
Hydrostatic and the other pressure, right? The colloid.
Well, it's hydrostatic because that's fluid. Colloid is protein.
Colloid is, okay, protein
Yeah.
solutes, hydrostatic
Right.
is water.
Yeah.
For taller people, do they have a longer vessel length?
You know, they're going to, but proportionally, they're probably going to have a larger heart. So I think it's a proportional thing. So their heart's going to be working harder than Frodo Baggins' heart, you know, because he's shorter.
So short
Although he's
people
got really
have
big
smaller
feet,
hearts?
so.
So so short people have really
Yes.
short ones.
What animal has the biggest heart on the planet?
Elephant.
Which whale?
The shark whale, shark?
Blue whale.
Interesting.
The blue whale. There was one in some museum, and there was a person standing by it. I was like, good grief.
How big was it? Can you
Huge.
give a little estimate? Like how big?
I don't know.
Next to
It just a visual estimate, but I don't know. That's the biggest heart.
Like this big?
Look it up. Google image. All right. Now, the place where you make a difference as far as lowering blood pressure is when we talk about the radius of the vessel. So if you increase the radius of the vessel, what do blood vessels have to do to increase the radius? What do we call that? When you dilate the vessel, you increase the radius, the internal radius. That's going to make it easier to move blood, and that's going to decrease your blood pressure because there's less resistance. If you constrict the vessel, what happens to blood pressure? It goes up. It goes up. All right? Now, if you constrict it like a precapillary sphincter, if you shut it off, well, there's no blood pressure on the backside.
If you decrease it, it gets less pressure.
Well, if you decrease it, the heart is still pushing hard, and the pressure coming through, that's going to increase the pressure to move the blood effectively. Yeah, and you can decrease it to the point it's not flowing at all. On the backside, that's where the pressure's lower. Yeah.
So, how does that, like, I'm just trying to make sense of that, right? Because when you have a hose and you replace it for a smaller diameter hose, water will come out faster at a higher pressure.
Well, how much? We're talking about output versus pressure.
Oh, okay.
Yeah. The last slide here, and then I'll get to your question, Hugh. Blood volume. You got more volume, you're going to have higher pressure.
Two questions.
The heart's having to pump more blood, higher pressure from the heart, higher pressure through the vessels.